The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. I'll be your host today. My name is Casson, and I'm one of the general surgery residents at Washington University in St. Louis. I'm joined today by Dr. Paul Wise, one of our colorectal surgeons and our Vice Chair of Education. Thanks so much for joining us today, Dr. Wise.
Hey, Cam. Great to be here. Thanks.
In this episode, we'll cover common surgical diseases of the small intestine. Almost every subspecialty of general surgery will manage patients with these conditions, so hopefully you'll find the following conversation relevant and informative. Let's start with a case to guide our discussion. A 65-year-old woman who presents to the emergency room with 12 hours of worsening abdominal pain, nausea, and emesis. She has a history of an open appendectomy as a child and a total abdominal hysterectomy. What other history would you want to know, and are there any imaging or lab tests you would want to obtain?
Cam, it's a great question. Obviously, both within colorectal surgery as well as within general surgery, small bowel obstruction is something that we frequently get called to see. So taking care of these patients is something we're pretty familiar with. I think as you can appreciate as a consult resident, I mean, one of the first things you want to know is whether the patient is sick or not sick, right? Whether they're likely to need an operation urgently/emergently, or whether or not this is something that you're going to be able to manage non-operatively. But of course, first starting with the basics, you're going to do your usual history and physical exam, certainly wanting to know other factors about the patient that may impact their safety to go through a big operation. Are they on anticoagulation? Things like that. So basically, what are their comorbidities and what's their likelihood of being able to make it through an operation? But you already mentioned the fact that in this particular case, this has been going on for 12 hours. They have a history of prior abdominal operations. And so having completed that history, heading towards doing your physical exam is really going to be the next step. And of course, I'm wanting to see if they've got evidence of peritonitis or anything that's going to push me to need to go to the operating room sooner, certainly if their vital signs are quite deranged and they're showing evidence of a more progressive or progressed pathology. So if they've got evidence or concern that this is a circumstance with strangulated bowel, and therefore that bowel may be ischemic or infarcted, or certainly if the patient has evidence of perforation, then that's someone who's going to need an operative intervention sooner. That being said, once you've done your initial exam and assuming there's nothing that's pushing you to think they need an urgent or emergent intervention, having labs, including a white blood cell count, lactate, certainly other electrolytes as needed to be able to determine the patient's state of their both potential ischemia of the bowel, evidence of inflammatory state, and concern about acidemia that may suggest, again, that they may have ischemic bowel, or other derangements that may just be related to dehydration from having the bowel obstruction.
Is there any imaging that you'd want to get for this patient?
Yes, and I think commonly a lot of our patients have had standard abdominal x-rays. So whether that's that, kidney, ureter, bladder imaging, or just abdominal x-rays, flat and upright. Some providers also like the side view image to look for evidence of free intraperitoneal air. But the majority of the time, and as you know, most of the patients who are coming through in a more acute setting in the emergency department, usually we're being called by the time they've had cross-sectional imaging in the form of a CT scan. And that can be incredibly helpful because it gives you an idea about not just what's happening in general with the bowel, but hopefully more specifically as to the potential etiology of it, whether there's evidence of an inflammatory process, a mass, a hernia, or certainly concern about an adhesive obstruction, which is the most common etiology, certainly that we see in the United States as the source of it. And in this patient, I suspect that'll be the case with them given their prior history, but you don't want to take it for granted. And so I do think that cross-sectional imaging can be really helpful. Of course, it'll also help to delineate a little bit the grade of the obstruction, whether it looks like it's a significant high grade versus a lower grade or partial small bowel obstruction. And then, of course, whether there's evidence of a closed loop obstruction or other things that may make operative intervention a little bit more necessary in the shorter term, even if the patient is otherwise stable.
Great. Thank you. Let's take a step back for a second now and talk about some of the causes of small bowel obstructions. You had mentioned kind of one that you were thinking about in this patient, adhesions, which you mentioned was kind of the most common one that we see here in the United States, often due to prior abdominal surgeries. What are some of the other common causes of bowel obstructions that we see?
Hernias are really the most common cause worldwide and the second most common cause in the United States. And that can be ventral incisional hernias, certainly, but also commonly inguinal hernias or femoral hernias. And so looking for those as an etiology, and many of those can be noted on physical exam, but some of them do require cross-sectional imaging to really clarify whether that's the source. Other causes are much less common, but certainly we do see them, such as, say, intestinal volvulus, which I find, especially in adults, usually is related to adhesive disease. There's an adhesive band that the bowel twists around. Intussusception is something that we will sometimes see, usually with a lead point or intussusceptum, that can cause problems with the intestine telescoping into itself. Frequently in adults, that's related to tumors or polyps, so some type of growth that leads to that. We can see strictures, radiation enteropathy, inflammatory sources such as inflammatory bowel disease, Crohn's disease, or even ischemic strictures sometimes in patients can cause small bowel obstruction. And then, of course, other external sources can cause that as well. So if there's a tumor, abscess, hematoma, et cetera.
Let's go back to our patient who didn't have any of those worrisome findings that you talked about earlier, that often, pressing us to go to the operating room emergently. So we opted to trial conservative management with bowel rest and NG tube decompression. How long do we let her sit with an NG tube before we decide that we need to go ahead and take her to the operating room to try to address her underlying problem?
Yeah, that's a great question, and one that I think is really individualized patient to patient, because it certainly depends on their clinical status, right? So if the patient has any kind of clinical decline through the process of your care, that may necessitate earlier operative intervention. But if they're stable, you do have the luxury of time. And while you certainly don't want to wait too long if you can avoid it, meaning if you need to intervene, trying to intervene sooner rather than later, not only so that the patient doesn't have to suffer any longer than is necessary, but the earlier you intervene, the overall the likelihood of them having a shorter length of stay and overall better outcome is much improved. So if it looks like they're going to need an operation, we want to try and do that sooner rather than later. But the majority of the time, especially with adhesive small bowel obstructions in a stable patient, we can usually manage those successfully non-operatively. So in the past, it was really just nasogastric tube. It was intravenous fluid resuscitation, supportive care, serial exams and labs, and just giving them time. But relatively recently, there was the note, and now there have been a lot of studies looking at it, that using water-soluble contrast, so an osmotic load, to do a small bowel challenge, as we call it, to be able to essentially kind of test where that obstruction is and to be able to see if we can actually open it up with non-operative techniques will be successful. So using, for example, something like gastrographin or another water-soluble contrast agent, not barium, but use a water-soluble contrast agent through the nasogastric tube, usually doing that within 24 to 48 hours of their initial presentation to challenge it and see if you can resolve the obstruction can be quite successful. If that's not successful, and you note that the contrast does not pass beyond the area of obstruction, does not get into the large bowel or beyond, then, or the patient doesn't clinically resolve, that pretty much tells you that that person's going to need operative intervention. There's actually a really nice algorithmic figure in the Washington Manual and the chapter on small bowel intestinal issues that I think is incredibly useful under these circumstances.
How about a different patient situation that we get called about quite a bit as the inpatient console residents? Patient who's coming with a obstruction due to a non-operative lesion, such as carcinomatosis. Is there anything as surgeons we can offer for these patients?
Yeah, I think those can be really frustrating consults, not only because, surgeons, we want to have a chance to operate and hope that we can help the patient. And while we might be able to potentially relieve some of their symptoms, it's in a more global circumstance where that's not likely to have a long-term success for the patient. And a lot of times the referring physicians or the patients themselves and their families really look to us and kind of think of us as their last resort. I think of these patients from a multidisciplinary perspective and recognize that they need us, but they also need the oncologists and other individuals who will be involved in their care, really focusing on goals of care and kind of focusing on that initially. But if this is someone who has got some potential longevity and that they may have other treatment options that are available to them such that we can find a perhaps either less invasive or some type of palliative operative intervention that might be successful for them, even if it's temporizing, then we think about things like a decompressive gastric tube. And those can often be placed endoscopically and may not need operative intervention. So whether with our IR or GI colleagues or with our general surgery colleagues, that those can be placed. But certainly there are times when if there's a focal lesion that's causing an obstruction that may not be operative or resectable, we can do a bypass. So we can do a small bowel bypass or a palliative bypass that can be done. And sometimes that can be done even with minimally invasive techniques, either laparoscopically or robotically, to be able to bypass the area of obstruction, palliate the obstruction, allow the patient to be able to get back to eating and drinking and hopefully get back to therapy if that's an option for them. And sometimes that can even make it such that we're able to get the patient in a better setting where later on, if they are resectable, we can look at that as an option for them.
Great. I think that was a really good, thorough review of small bowel obstructions, which is something that we see quite a bit. So let's go ahead and move on to our next case. Now we have a 25-year-old man who is referred to your clinic due to pain and drainage from his bottom concerning for a perirectal abscess. Upon further questioning, you determined that for the past several months, he's been having this cramping abdominal pain, diarrhea, and weight loss. What are you concerned about in this patient, and what steps would you like to take next?
Yeah, great question. So this is something that we commonly see in our colorectal surgery clinic as a patient who shows up with a perirectal abscess or fistula. And there are some other concerning symptoms that go along with it. And so certainly this would raise my hackles for the potential for this patient to have a more systemic process going on, in particular thinking about Crohn's disease or inflammatory bowel disease with a patient like this. The majority of the time when we see the perirectal pathology, it's usually cryptoglandular, so not related to underlying inflammatory bowel disease, and certainly referring folks to the chapter in the manual related to anorectal pathology can be helpful to try to think about that specifically. But you always want to have in the back of your head, could there be some other etiology of this beyond something that's cryptoglandular? And certainly we think a lot about not just malignancy or STIs or other sources, but inflammatory bowel disease is something I always have on my differential, especially in a young person, and especially if they have systemic symptoms. So in this case, with abdominal pain and diarrhea and weight loss, I would have Crohn's disease high on my differential.
When you're having a patient that's brand new concern for Crohn's disease, what are some of your first steps for working up that patient?
Yeah, so if they haven't had an evaluation or haven't been seen by our medical or GI colleagues, then really starting from scratch and thinking about how to clarify that. So if the abscess itself seems to be relatively straightforward, they may not need any imaging for that. But given this patient in particular, their abdominal complaints, I would think about some type of cross-sectional imaging for them. And when you're concerned about the potential for small bowel involvement or intestinal involvement above and beyond the anorectal disease, thinking about doing CT enterography or magnetic resonance or MR enterography can really be helpful, because not only does it give you, hopefully at least a start towards a diagnosis, but will also clarify the extent of the pathology. But really the gold standard for assessment for inflammatory bowel disease is endoscopic assessment. So I would want the patient to undergo a colonoscopy and make sure that that endoscopic assessment, whether I'm doing that or it's one of my colleagues, includes assessment of the ileum if possible. So making sure that they get an assessment there, plus or minus biopsies. But certainly if you see evidence of obvious pathology there, want to make sure that we get biopsies in both the small intestine and the colon to clarify the etiology of it and basically confirm the diagnosis.
So let's say he undergoes that workup, has now been diagnosed with Crohn's disease. What are some of the basic tenets of management for this patient? When do medical management come into play, and when do we as surgeons need to get involved?
Yeah. And so that, again, kind of hearkening back to the discussion we had about that complicated patient with carcinomatosis and that being a multidisciplinary approach. Same thing with inflammatory bowel disease. It's truly multidisciplinary. And so we have a very close relationship with our GI colleagues and focus on what's going to be best for each individual patient and how best to manage them. And so because Crohn's disease in particular is not considered to be curable, we really focus on the medical management. And these days, our options are numerous in terms of the medical options, medical therapy options, but also the success of those options. And so in the past, it was really limited to different ASA products, and steroids as really our only options. But over time, immunomodulators, and then more recently, pretty extensive options with biologic therapies. And we've got a whole host list of those within the manual, the chapter, that I think are really helpful for the listener to be able to get a full appreciation of the extent of those options. But we found them to be incredibly successful with our patients, and sometimes can delay or maybe even completely eliminate the need for operative intervention. In this patient's particular circumstance, however, if they've got a perirectal abscess or pathology there, making sure we've controlled the sepsis in this circumstance and treat that. And so that'll probably need some type of operative intervention to help drain it. But in terms of the abdominal pathology, if they're able to maintain weight, in this case, they did mention weight loss, but if we could focus on better dietary approach for them, and make sure that their otherwise quality of life and function and ability to work or go to school, et cetera, is doing reasonably well. Hopefully we can delay or avoid need for surgical intervention for this patient. But certainly if medical management is failing, obviously if they have a more acute circumstance with perforation or severe bleeding that can't be controlled with medical management, or an obstruction that's just not responding to steroids and other medical management, this is someone who may need some type of operative intervention for their small bowel disease. When we're thinking about operative intervention for these patients, we're really doing everything we can to preserve normal bowel and address pathologic bowel. So whether that's resecting the bowel that's pathologic with or without an anastomosis, depending on the patient's clinical circumstance. In this case, if it's a 25-year-old male who we've gotten his perianal disease under control and he's failed medical management for his abdominal disease, then thinking about as long as their nutritional status is okay and they're not on high-dose steroids that may impact postoperative risk for complications, then thinking about putting them back together again and doing an anastomosis after doing what would likely be what we call an ileocolic resection, resecting the involved portion of the ileum and the very proximal portion of the large bowel, and being able to anastomose them. But if they're not in that kind of circumstance or on high-dose steroids, they're malnourished, they're clinically unwell, then I think considering doing an endoleostomy, getting them clinically better, and then going back in the future and reanastomosing them, assuming their disease is under control, is very reasonable. A stricturoplasty is something that we can also consider if they've got, say, multiple areas of small bowel that's involved, or we're worried about leading them to what's called short gut syndrome or not having enough intestine to absorb nutrients. Then doing kind of a local revision of the bowel and not actually resecting it can be very successful. And notably, symptomatic recurrence for Crohn's disease, if we do a resection versus a stricturoplasty, is actually the same. So it's notable that you can just revise the bowel and hopefully make it such that their likelihood of having symptomatic recurrence is relatively low, especially in the setting of being on good medical management.
Interesting.
Yeah.
You had kind of mentioned already that this is a disease that can't be cured, and we do have some really good new medical therapies these days. But what does kind of a long-term prognosis look like for these patients?
Yeah, somewhat variable, and again, related to their individual and almost like what their phenotype is with the type of disease that they have. But I am seeing that now with our litany of options that usually our gastrointestinal colleagues are able to find a regimen that works well for most patients. So the prognosis is actually quite good. But if someone has a biologically aggressive disease where they're requiring multiple operations, which frankly we just don't seem to see nearly as much now as we used to in the past. Odds are they're going to do well. There is the potential for even a bowel transplant in these patients, but obviously that's taking it to the extreme and tends to be more due to the short gut syndrome from multiple prior resections than it is related to the disease itself. But certainly is a potential with these patients.
Great. And then one last point here. I think you were alluding to it earlier when talking about workup for these patients, making sure you get biopsies of the colon and the ileum. But can you just comment a little bit about Crohn's versus ulcerative colitis and kind of how that plays into management of these patients?
Yeah, it's a great question when you're considering a patient with inflammatory bowel disease. And one of the most important things we can do is assess the extent of their disease. Ulcerative colitis is a circumstance where it'll be isolated to the large intestine, so we shouldn't see small bowel involvement with that. Whereas Crohn's disease can involve the entire extent of the GI tract. Probably around 55 to 60% of the time, Crohn's involves the terminal ileum. Only about a quarter of the time will it involve the small bowel only, and about maybe 15 to 20% of the time it's involving the large bowel only. So there can be some overlap with ulcerative colitis and Crohn's if it's isolated to the large intestine. But how that phenotype manifests itself, whether it's fistulizing disease or stricturing disease, et cetera, that tends to be more on the Crohn's disease spectrum than ulcerative colitis. But both of these conditions can put patients at increased risk long-term for neoplastic change, so developing small or large bowel cancers in Crohn's disease and large bowel cancers in the setting of ulcerative colitis. So something to think about, and we want to make sure that we keep that in mind as we're thinking about operative interventions for these patients and what they might be a candidate for or might not be a candidate for.
Thanks so much, Dr. Wise. That was a really thorough overview of Crohn's disease.
We hope you enjoyed this installment of the Washington Manual of Surgery podcast. Stay tuned for part 2 of this episode to learn more about the classification and management strategies for small bowel fistulas. We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.